Okay, so welcome everyone. Welcome to Journal Club, our March Journal Club from Journal Chest. And today we have a really interesting article from this month's journal about beryllium disease due to environmental exposure rather than occupational exposure. So I'm gonna get started by introducing everyone. My name is Divya Patel. I'm from the University of Florida. I specialize in interstitial lung disease and sarcoidosis. I have here with me Viren Kaul, who's an assistant professor of medicine at SUNY Upstate. We are lucky to have two of the authors of the article. First, we have Dr. Gernot Zissel from the University of Freiburg and Department of Pneumology, and also Dr. Björn Frye, who's also from the University of Freiburg, Department of Pneumology. We're really thankful for them being here with us, especially because of the time difference. And then finally, we have our content liaison, Dr. Raed Dweik, who's the chairman of the Cleveland Clinic Respiratory Institute and runs the beryllium disease clinic there as well. So thank you so much for joining us this afternoon. We're excited to discuss this interesting article. And let's get started. So first, just to go over the learning objectives quickly, we're going to review some of the immunopathogenesis of chronic beryllium disease and try to understand how beryllium lymphocyte proliferation tests are performed. We're going to also talk about specific exposures that are known to lead to chronic beryllium disease and try to understand the unique aspects of the cluster of beryllium sensitized workers in this paper. Quickly, the only disclosures we have from the speakers today are from Dr. Björn Frye, and he's listed his relevant disclosures there. So let's get started. I'm going to start out with Dr. Frye actually and ask him about how does beryllium affect the lungs and what do we know about the pathogenesis of that?
Okay, so first of all, beryllium must come to the lungs. So the normal route is the inhalation route. So we need beryllium containing dust, beryllium containing aerosols that are inspired by individuals. And the second aspect, one must know that beryllium is very small, and by itself it cannot be immunogenic. And what happens in the lungs most likely is that beryllium changes the antigen presentation by conformational changes of the HLA complex. And this leads to a T cell response because the T cells are confronted with novel conformations that haven't been known before to them. And so they proliferate and they cause a alveolitis. And so ongoing exposure to beryllium leads to an ongoing alveolitis and at the end to the, let's say, frustrated reaction of the immune system, that is granuloma formation. And this granuloma may lead then to fibrosis, to distortion of the airways, so making the full picture of what we know as chronic beryllium disease. So, and for the moment, I think it's not completely clear what exactly happens, but we know that certain genetic alterations, especially in the HLA gene, predisposed to beryllium disease. And there has been a very recent paper, I think, that shows that maybe beryllium might be toxic to the alveolar macrophages, causing first inflammatory response, and that chemokine peptides may form novel antigens that can elicit a T cell response. So that is at least what I understand is chronic beryllium disease.
Great, thank you so much. Dr. Zissel, if you could talk about what is a beryllium lymphocyte proliferation test in general, and like why and when it would be used.
In general, the proliferation test means that you activate a T cell by an antigen, which starts to proliferate. That's actually what a T cell does if it is activated, if it is stimulated by an antigen. And in this test, we stimulate the T cells, or let's say the peripheral blood cells, the white cells, with beryllium. Keep them in culture conditions for 4 days or 7 days. And afterwards, we measure proliferation by incorporation of BRDU. So this can be detected by an antibody, and the amount of BRDU incorporated into the cells mean that these cells proliferate very strongly. If they do not incorporate BRDU, that means they did not respond, did not proliferate, and then this would be a negative test. So in general, proliferation test means you stimulate a cell that proliferates and you measure the proliferation.
That was great. Dr. Dweik, can you review with us, like, what is the difference between beryllium sensitization and beryllium disease? Like, what distinguishes those things?
Yeah, thank you for asking that. So I like to think of it as really stages. There's exposure, and there's sensitization, and there's disease. So those who are exposed to beryllium, some of them get sensitized and some of them do not. Sensitization basically is the immune response. And that's detected by, as mentioned earlier, by the beryllium lymphocyte proliferation test. Not everybody who's sensitized progresses to beryllium disease, but it's always a stage. Sensitization is a stage that precedes chronic beryllium disease. So really, chronic beryllium disease is defined by having end organ damage, so involvement of usually the lung, but it can involve other systems, and typically having non-necrotizing granulomas, but it can be other forms of interstitial lung disease. And that's really the progression in my mind: exposure, then immune response, which is sensitization detected by the lymphocyte proliferation test, and then the disease, which is detected by pathology, usually either by radiographic changes, but more importantly, by getting pathology from the lungs or the affected organ to show non-necrotizing granulomas or compatible pathology with the disease.
So maybe one point to point out at this point, which might be difference in Europe from US, that as you ask, when we do the beryllium lymphocyte proliferation test, in our clinic, we normally get samples from patients that have been already diagnosed with sarcoidosis. And the physician is aware of this occupational related disease. The patient has an occupational history, making beryllium exposure likely. And so in this cohort of patients, we are asked to perform the beryllium lymphocyte proliferation test. This might differ from the surveillance programs established in beryllium handling industries in US.
Yeah, that's a great point. And I think I want to add to that most of the patients that I see in my practice now are the second group, which is being under surveillance from the workplace. So they come often asymptomatic and no diagnosis, just a positive LPT test. And then we have to determine then how to evaluate them clinically to determine whether they have chronic beryllium disease or not. Clearly, this paper was almost the opposite, where they had a patient who had a granuloma, and then you investigated whether they have beryllium disease or not. That's a great point. Thank you.
Perfect. So Dr. Dweik set me up really nice. So what happened in this study, and I'll take credit for the work here, right, guys? So is you have a patient who, looks like they have granulomatous lung disease, diagnosed with sarcoidosis. And I think we've all been in this familiar situation. You rule out the common stuff, so you're left with this granuloma. But for some reason, you you decided to think about berilliosis, right? Or beryllium sensitization, I should say. So what was it that increased your index of suspicion? Because I think this is what's going to give the rest of us sleepless nights, right? How many beryllium-related diseases have I missed?
Well, indeed, it might seem a little bit strange, but in this case, we really listened to what the patient told us. So, well, normally we have a questionnaire for a department how we assess how likely beryllium exposure due to occupational disease, occupational exposure might be. And this patient, he had no occupational history of direct handling with beryllium dust. But what he mentioned is that his symptoms started, at least he associated us with increased dust exposure at his working place. And he always said, well, when I wanted to go home, I had to clean my car to have the glasses free to go back to home, because there came so much dust from other companies to our place. And so he was indeed well educated. He looked what is there with dust, with sarcoidosis, and somehow he found out that there is this disease called berylliosis, or chronic beryllium disease. And so indeed it was him who gave us the hints to make this test. Indeed, in the normal routine, just giving him a questionnaire about his work wouldn't have revealed that he's a high risk of having a beryllium sensitization.
That's interesting. So, you know how we typically don't consider case reports to be the pinnacle of science. I guess, you know, you guys did exactly that. You listened to your patient, essentially generated a case report in terms of interesting exposure, then kind of pursued that. So we'll move on to, and I'm going to hand off to Divya shortly. We'll move on to the next slide, which shows the table. So you identified your index patient and then decided to explore people around this index patient, trying to understand if they were actually sensitized to beryllium, because now your patient is sensitized to beryllium, actually technically has the disease. So how did you guys go about finding out this cluster, and walk us through, because this was a very detailed process, very meticulous. So you found a cluster of patients, you then started figuring out where this is coming from. So walk us through all of that.
Well, to tell the truth, also this has been a very nice opportunity at the end. The patient, he was very alerted for this disease, and we could not say, well, you have an occupational disease, because the assessment at the the Department for Occupational Medicine at Munich, they didn't find any hints for occupational exposure. So in his work, he was not working with any metals where beryllium dust could be released. So this was really, really strange. But he had this sarcoidosis, he had this association with dust at his working place, not deriving directly from his work. And so he somehow managed it that his colleagues became tested as well. And one must say that the employer, he allowed on a voluntary basis, so there has been no health regulatory saying everybody must go for a test, but the employer offered this to his employees. employees, and they came, so at least 2/3 about came to our department to make the beryllium proliferation test. And well, there have been 5 patients positive, and these patients, we looked a little bit closer. So I will not call them patients because indeed they weren't diseased. So they were at least volunteers. They had this positive LPT. And so we looked then for lung function. We did some X-ray. We looked for symptoms. We had this one female who reported cough, but we did not find any further hint, even in bronchoscopy, of lymphocyte alveolitis. So at the end, we said, okay, we have here patients that are beryllium sensitized. We informed them about what this means, that it may lead to chronic beryllium disease at some point, that they must be aware of this. But however, all those patients, they didn't come back to us. So we hope that even after these years, they are still quite healthy and do not have any related diseases. So yeah, that was the way it worked out. Perfect.
So Dr. Zissel, this here is on the top panel showing your beautiful investigative work. We have in that blue star, that's the company where your workplace. The yellow star is where finally you guys, after your investigation, figured out the beryllium exposure is potentially coming from, which is not these people's actual workplace. It's another concrete factory which is near there. Right. But you also, in this process, created a map which helped you understand how these people got a non-occupational exposure. So how did you guys figure that out, and what were the unique properties about where these guys who were beryllium sensitized lived?
Yeah, as Björn told us before, so you need to have beryllium in an inhalable form. So to us, it was very likely that there must be dust, something like that, which is containing beryllium. So we gathered dust samples from this area, but also from other non-related areas, just to have an overview. The point is that in Germany, beryllium is very badly monitored. So there are some sporadic values concerning the beryllium concentrations in dust, soils, whatever, but there is no regular surveillance of beryllium. So we collected these samples, and we also, we were really naive. We have no knowledge about beryllium concentrations in dust, in soil, whatever. So we read something, and then that came out, okay, there might be some sources in the surrounding because there is a combustion company, there is these concrete companies. So we try to collect and to narrow where it might come from. So if it is not the occupational disease, so it might be an environmental disease. So that's what we try to figure out. The main wind direction is shown here, this triangle. We thought, okay, there must be a source of beryllium. If it is not the company itself, it must be in the surrounding, and try to get a clue where it might come from.
And so you showed that the patients who were beryllium sensitized lived closer, their home was closer to their workplace, and then also to the concrete factory where you think that the beryllium originated.
Right.
Okay. So
let me just clarify a point, if you don't mind.
Sure.
That you mentioned the inhalation part, which clearly for lung disease, inhalation is an important route, the most important route. But you can get beryllium sensitized through skin and mucous membranes as well. And we've seen that in industries. Usually you don't get lung disease, but that, this is something the companies in the US have done over time, is to minimize skin exposure, to minimize sensitization, but still, of course, inhalation is key for developing long chronic beryllium disease. I just want to clarify that.
I would ask you, is it enough to get, if you have skin contact with beryllium, is it enough to get lung disease, or is it enough to have sensitization?
Sensitization usually.
Sensitization, right. Okay.
Right. Thank you.
Okay. So I think we kind of addressed the first part of question 3. You know, if it wasn't from occupational related, what else could it be? Besides the concrete factory and was there anything else that you were suspicious of besides the concrete factory as a source of beryllium when you were doing your investigations of the area and the environment?
Yeah. So the workers there, they work in road maintenance. Mm-hmm. They work in every related stuff. So maybe asphalt would be a source of beryllium too, because there are some additives. Fly ash may contain beryllium from combustion, for example. But what we found was very inconclusive. There might be some beryllium in, but it's not in that masses. And second, again, you need to have inhalable particles, which is not given in asphalt, but you have it in the dust from the concrete.
Okay.
So they don't produce fresh concrete. What these companies do is they recycle old destruction concrete.
I see.
And during this process, you have a lot of dust. If you don't care, then it is spread out, and which is really inhalable.
Yeah.
Can I comment on this, Divya, as well?
Sure. Go ahead.
So clearly, occupational exposure here with beryllium is tricky because how to identify it. Of course, a detailed occupational exposure history is important, and et cetera. But to say until the early 90s, most of the exposure happens in either the primary industries that produce beryllium or in nuclear and aerospace industries.
Right.
But really, since then, now there are hundreds, if not more, of industries that utilize beryllium in alloys, like all the way from, of course, in the cars, in computers, in planes, even in things as golf clubs and mountain bicycles. So I want to just emphasize the importance. It's not just your usual beryllium, occupational history. Sometimes it may be a subtle exposure. But to emphasize also, you have to really be inhaling the dust. So it's not just having golf clubs that have beryllium in them that's the exposure. If you sand them down or disturb it in some way, that generates dust. But the companies that make those, I think their employees are at risk of exposure to beryllium. And I just want to emphasize that because historically it's been certain traditional industries, but now it's a lot of industries use beryllium in different settings. Thank you.
So in the U.S., Dr. Dweik, I know the U.S. government is very much interested in like the beryllium in the nuclear industry and aerospace, but like is NIOSH or OSHA watching these other newer industries also, or keeping track of exposures in those newer industries?
I'm not aware of any active tracking going on, but definitely when beryllium is shipped to these companies by the primary producers, it's labeled, with its hazards, etc. Now, but it's up to each company how they handle it and how they inform their employees, etc. And that's, I think, an area that would require probably a lot more attention from us, especially that, when companies who are used to dealing with beryllium, they are aware of this, they do surveillance, as we said, we do screening, but companies who are not primarily dealing with it, that's where the risk of, I think, we underestimate the number of people exposed occupationally to beryllium in that regard. Another big one, actually, which I don't think is a big deal in the US anymore, is dental implants. Mm-hmm. Historically, some of the dental fillings and implants were contained beryllium. I don't know how often is that happening in Europe, but I think it's not as common in the US anymore. But it's not, having the implant may expose you because there's beryllium in it, but also the dental technicians. There's outbreaks periodically in dental technicians who sand these fillings and implants that may get exposed. So I think we need to be hyper vigilant and thinking outside the box when thinking occupational exposure and beryllium. It's not just as straightforward as may seem. It's not like other occupational exposure with dust or silica that's obvious. Beryllium is in so many things now in the form of alloys that we need to be more aware of these things.
Yeah. I would like to add, so in dental technicians, it was the first accepted occupational disease, berylliosis. So indeed, we had the problem with beryllium containing implants and all these brackets and whatever. But since the 19th, I was told that since 90s, it is out. So there is no beryllium anymore. I'm not sure because it's not clear where all the material comes from. But that is what I already hear from the dentist.
Okay. One couple other things we wanted to ask the authors. Is there any possibility there was a different occupational that was missed in this? And to add to that, like, what would be the limitations? Do you think that with these 5-6 patients, 5 that are sensitized, 1 with beryllium disease, is that enough to say that this concrete dust, contains beryllium, and that, the workers that are exposed to this concrete dust should have protection, special protections, and things like that?
Wow. Let's start with the first question. Well, for the index patient, we are quite sure that we did not miss any previous occupational exposure to beryllium because he was assessed at a specialized department with a colleague. We have a close cooperation. Caroline Quattrucci is co-author. And she and her boss they looked very closely to this patient to really rule out that there has been any other occupation suspicious of beryllium exposure. So for the other people that have been sensitized, we ask them for their work and we ask them for their previous work. However, we were mainly, let's say, interested in seeing do they have a disease rather than do they have a previous work where it could be possible. However, one must admit, knowing the German occupational structure, these persons, they normally do not change their workplace very often. They live in this village, they work there, they have a public employer, and so we do not think that there is that there are so many, that they all came from other occupations where they had beryllium exposure prior to entering this company. However, you're absolutely right. Just having 6 patients with beryllium sensitization, one of them with chronic beryllium disease, and having finding some elevated beryllium concentrations compared to other dusts does not necessarily prove that there is a causal relationship. However, one must say that beryllium sensitization is, at the end, not a very, very common thing. And we have this time link of this concrete dust being blown. The patient who became diseased, the same persons who are who are working there, and even living closer to the region where the dust concentrations might be higher, so having also exposure afterwards. However, there might be even another company we did not consider, where we did not look. So I would say that this is one major limitation. And the other thing is that we would have liked to investigate the workers at the concrete company, maybe workers that work at, I don't know, the post office nearby or the supermarket nearby or whatever, just to see if they have similar percentage of beryllium sensitization or so, but this was not possible. And so because everything happened on a volunteer basis. So.
Yeah, go ahead, Björn.
I just want to add one thing. So if you ask, might we have missed an occupational exposure? Maybe, don't know. But I would turn it back. So when we start investigating the dust, my maybe naive idea was there should not be any beryllium in. Mm-hmm. But in fact, we found beryllium. So this is what was first astonishing me, and we found it in very different concentrations. And then we start reading, start learning, where is beryllium? Is it normally out there? Is it exceptional high here? And we have to say, no, it's not exceptional high, but it is higher than in other areas. So I don't care what beryllium, what is in granitic rocks or wherever, but I care about beryllium, which is in inhalable dust, in the surrounding, in the environment. And that is something what astonishes me and which deserves attention.
Yeah.
So on that, just taking a hint from that, Mohammed Rashad, one of the attendees, he has a few questions. One of them, he's stealing my thunder, but that's totally okay. So the first question is, how is a positive LPT enough to diagnose chronic beryllium disease? Because Dr. Dweik did mention it's a spectrum. So Dr. Dweik, and I know I shared a recent review that your group had written on this, right? Metal allergy, it was called. Very well done. So can you explain how you clinically use to differentiate the two entities?
Yeah, so currently, since the lymphocyte proliferation test was developed in the early 90s, the sensitization or a positive LPT is required for the diagnosis of chronic beryllium disease, but not sufficient. So what you need on top of that is, as I mentioned earlier, some form of pathology or involvement of the organs. Most typically is granuloma, non-necrotizing granuloma on lung biopsy. That's usually typically how we make the diagnosis. So a positive test only indicates the sensitization part. The pathology with the positive test makes a diagnosis of chronic beryllium disease. Having said that, the definition of chronic beryllium disease has evolved over time. Before, like there's a beryllium registry before the lymphocyte proliferation test was developed, and the diagnosis there was purely by pathology and by radiology, by X-ray and pathology, and that's really how it started. But once we developed the lymphocyte proliferation test, it became an integral part of the diagnosis now for clinically, but also for regulatory agencies. So to me, to have a diagnosis of CBD, you have both a positive blood test or lymphocyte proliferation test on the lung. That's another option to do it on lung lymphocytes, but also pathology compatible with the disease.
Perfect. So we now understand, and I know this is not exactly the same, but when I am sometimes doing teaching on this, I say it's a little bit like quantiferon is for like TB disease, right? It's a little bit the same way, not exactly, but just to get it to stick. But the next question, which I was very interested in asking you guys, was there is data to show that sarcoidosis, patients with known sarcoidosis, or at least what we think is sarcoidosis, tend to have higher amount of metal-related diseases, right? And it's hard to say if they are different entities or are they coexisting. So let's say a patient had coexistent sarcoidosis and say beryllium disease. How would you ever know, or do you tend to finally pick one bucket for them? And Dr. Dweik, you can go first and then our authors can go.
This is one of the toughest calls to make, actually. So, and if somebody comes in who's clear history of exposure to beryllium and has a positive blood test and has granulomas, it's really hard to call them sarcoidosis. The harder one is somebody comes who works with the beryllium plant, for example, or has clear history of exposure and has granulomas, but a negative LPT test. That's, to me, is the most difficult call, because how can you, the two sides to it, how can you call somebody who's exposed to beryllium with sarcoidosis, but also how can you make a diagnosis of beryllium disease without an LPT? And this is something that creates a dilemma for me clinically, and something that we have to take on a case-by-case basis. The ideal situation, if you have a positive LPT, it's not sarcoidosis, done. You cannot diagnose sarcoidosis with a positive LPT. The dilemma comes when you have a negative LPT with somebody with documented exposure to beryllium. How many people in a beryllium plant can you call sarcoidosis? That becomes tricky, and I think has to be taken into account.
And may I ask, to me, it's not astonishing. So CBD is to 90% related to special HLA-DR. Clue69. So if you don't have a Clue69, you have a very small chance to get a CBD. So why not? You may have beryllium in your lungs, but you don't need to have berylliosis.
So is that interaction, right? I think that's what I was thinking also, is how much of it is interaction with your antigen and how much your body reacts to it, right? Because at the end, that's, I think, the interaction you're looking for.
Yeah, the way I like to think of genetic testing, and that's a great point that has not come up until now, which I think is a good point. So there are a couple of ways, multiple ways to think about it. So definitely, current beryllium disease is a great example of a genetics environment interaction. If you have the genetic abnormalities, HLA Clue69, you are more susceptible to be sensitized and to get current beryllium disease. However, it's not necessary. We certainly have patients who have CBD, who do not have the genetic exposure. It increases your risk, but it's not required. So that's something, we don't use it in the diagnostic fashion. We use it sometimes in risk assessment before you apply for a job that involves beryllium. Sometimes genetic testing may be helpful to exclude those from, although that creates a lot of workman's issues. I'm not going to get into them here. That's beyond the scope of this webinar. But at least for the individual patients, if they want to know their risk, they can do genetic testing and say, well, I'm a high risk for beryllium disease. I might as well avoid this kind of job. It is not in the US legal for the employer to do this, however, because it becomes discrimination. But the individual themselves may want to know, and they are entitled, and they can make decisions. But if the employers are not allowed legally, because that becomes discrimination. So that's something I think important to think about.
Interesting. So, okay, so we talked about the role the HLA complex and the groove changes play, the interactions, right? So we talked about sensitization, we talked about disease, we talked about potential mimicking and where the challenges come with coexisting conditions. So here's the fun question, right? I think this is a little bit of a trick question. Are there any pathological features, I'm assuming on histology or biopsy, what have you, that can discriminate berylliosis from sarcoidosis?
Yeah, I can take that also as a start, because we've looked at that actually here at the Cleveland Clinic. And on the transfocal biopsy, you cannot tell. They're all non-necrotizing granulomas. Some of them are well-formed, some not well-formed, but that does not differentiate from sarcoid. However, there are some suggestions that if you look at open lung biopsy, and in some cases, that the granulomas in beryllium disease tend to be around the airways, as opposed to sarcoidosis, which tends to be around the vessels. Maybe that explains the fact that some comes from environmental exposure and some is not. But this is not really by any means a defining feature, but it's an observation. It's not enough to kind of make the difference. See, the only way to tell between the two, honestly, is a lymphocyte proliferation test. That's really the best way to differentiate the two. But there are some minor pathological features, as I mentioned.
So, Dr. Frye, could you, just to add to what Dr. Dweik just mentioned, could you use, for example, in sarcoidosis, usually you have most patients have multiple organ involvement, like lungs and maybe skin and liver. Is that something that you could use potentially to, like the patient that Dr. Dweik was mentioning, a factory worker who has exposure to beryllium, but has a negative lymphocyte proliferation test? Like, would a patient with chronic beryllium disease have other organ involvement as well?
I must unmute. Well, it is quite clear from the way of exposure that chronic beryllium patients have most likely involvement of the lung, that's skin and eyes, maybe some parts that are involved more. However, I'm at the end not quite sure whether the manifestation maybe of liver rules out that it couldn't be beryllium related to beryllium exposure. So at the end, I like the very old but the definition by Schelling, who says that we call it sarcoidosis. We do not know what causes the granulomata, and if we know beryllium causes it, and we have this lymphocyte proliferation test, then we call it berylliosis. However, I think that the most important point for the patient maybe is that if he's working in an environmental setting with beryllium exposure and he has the granulomatous disease, then besides treating it with steroids, the change of the workplace is what is needed for the patient. And that is, at the end, whether I call it really berylliosis because I have a beryllium LPT that is positive, or maybe he was started on steroids before I could take a beryllium LPT, and making it with 10 milligrams of corticosteroid, it becomes negative, and I could not interpret these results. However, he has granulomatous disease. He might have a risk factor that may propagate the inflammation and may lead to a worse outcome. So he should be consulted to avoid this and to maybe change the work environment.
Yeah, that's a really good point. And I think one of the harder issues, when you find these patients, sometimes financially it's not possible and things like that. Dr. Dweik, have you ever seen patients with beryllium disease who have involvement outside of like skin, mucous membranes, lungs, that could potentially help you differentiate sarcoidosis and beryllium disease?
Yeah, we've definitely seen it, but it's very uncommon, especially the type of patients that I see that are early on resulting from a screening test. But we've seen patients have cardiac disease and liver disease. The one feature that I don't see often, which is interesting, is adenopathy. Adenopathy is not very common in beryllium disease as it is in sarcoidosis. And sometimes, again, it's not a guarantee, it's not pathognomonic, but it's a hint that there's maybe something beyond. I had a patient who had significant adenopathy, and further evaluation revealed that actually they had lymphoma, which is completely separate. So if you see adenopathy in sarcoidosis, in beryllium disease, you need to look further. Don't take it for granted that it's due to beryllium disease. That's one.
Okay, that's great. Thanks for sharing that. One more question I have, Dr. Zissel, could you mentioned, prior to the start of this journal club that you have been testing a lot of people for beryllium sensitization. Can you talk a little bit about that, who you're testing, what your findings are, and what your goals are by doing that?
Normally we do it from peripheral blood, so from isolated mononuclear cells. What we often see is more or less positive cells, but very rarely really impressive cells. So we have a few patients with very impressive LPTs with high increase in stimulation indices. We have now maybe I told it, more than 1,000 tests performed. We do proliferation tests not only for beryllium, but also for some other drugs, for example, amiodarone, which is also causing a lung disease, and you have activated T cells activated by amiodarone. We did it also for other drugs. So that is widely used. So you can adapt this test to other stuff. So.
All right. So as we're coming close, and we're going to be shortly asking you guys to give us your top twos, right? Take-home points. But one question that is coming up from the audience is, so if you have patients who have sarcoidosis, should we be thinking about routinely checking LPTs? Which is, I know, but I thought this would be a fun one to ask.
The LPT is very laborious. It is a lot of work. We can perform maybe 3-4 tests a day for a single technician. And it takes at least a week or more to get a result. So this is, in my opinion, it is a very bad test, but it's the best we have. So what I wish would be a more easier test. Yeah, you mentioned before the ICRA tests, maybe. But what we see and others is that interferon gamma release and proliferation are not necessarily linked. It may be, but must not. So ICRA is not a possibility. So I would wish to see a test which is easier to perform than LPT before we say we test every sarcoid patient comes into our clinic.
You got it. And then based on your study, Dr. Frye, do you think if you find a patient who is appropriately diagnosed with either BPD or is sensitized in a work setting, what have you, that cluster analysis should be considered, more commonly? And Dr. Dweik, that's for you to follow up with as well.
Well, this paper describes at the end a pretty lucky situation, and where we had a patient who pointed us to perform a beryllium sensitive beryllium proliferation test. And we had the situation that others came that we could make this cluster analysis. I think for the clinician dealing maybe with sarcoidosis patients and noticing clusters, it might be interesting to investigate whether there are environmental factors, and beryllium is maybe one of the few environmental factors that we can test in patients. So I think from the scientific, from understanding of from understanding the disease, it is interesting to look for clusters, and this is one of the points we learned from this paper, and what we are going to look for, whether in Germany sarcoidosis clusters at different spots. So it has been described in the work for the Switzerland, and it has been described in a region in Italy, that there might be some clusters, and that is a little bit what we are looking for. And then going back to the environment and looking whether there might be beryllium in the environment or maybe something else. I don't know where this will end.
Yeah, let me comment on this one and the previous question as well. So I think the key to this, like almost any unusual disease, is to have a high index of suspicion. I can tell you, I've seen patients with seemingly unrelated industries like shipping, sometimes containers where they ship kind of beryllium-related things, and they have developed beryllium disease. But also the fact that some patients, individuals, are genetically susceptible. You can find it in unlikely candidates, like in beryllium plants, secretaries can have it just because, even though they have not set foot in a plant, just the fact that they're genetically susceptible doesn't take much for them to get sensitized and get beryllium disease. So I think the key is high index of suspicion. And then, like this team has done appropriately, is once you have an index case, is to like look kind of around and find what the source may be. Back to the question about whether we should test all patients with sarcoidosis and LPT is a good question, but I think it's more, instead of jumping to doing that clinically, I think it's time to do a study on that. I think it's reasonable for a center, something I've been thinking of doing for a while, never get around to it. But I think for a place that has a sizable sarcoidosis clinic, it's not unreasonable to do, a sampling of a certain number of patients and test and see what are the possibilities. And then if you have those positive, go back and do some tracing. Is there exposure or there is not? And that's going to be helpful. The other way, just to take this a bit further, be more provocative about it, Viren, is that you could argue that sarcoidosis is still a beryllium of unknown cause. Like berylliosis is a sarcoidosis of unknown cause. It's possible that sarcoidosis is caused by some other metal that's yet to be identified or some exposure. So I think keeping an open mind about, because we all, the origins of sarcoidosis are still the subject of a lot of publications and debate, whether it's a microorganism, whether it's a metal. Just have to keep that in mind, since we don't know what causes it, just keep an open mind when you have a sarcoid patient to look what may be causing it.
All right, so I'm glad you said that. I was hoping to not go there, but if people want to think about it that way, there is a sarcoidosis of unknown etiology. This is interesting paper. I think it was from, I'm looking right now, 2020 by Björn. They looked at patients with sarcoidosis and tested for organic and inorganic antigens, right? And this was very interesting. They found sensitization to aluminum, beryllium, silica, zirconium, mycobacterium. I believe there was propionibacterium as well. But anyway, point being, yes. So I'm wondering if that's what we learned, that it is, we just didn't know enough. And this is one of those environmental sort of second hits or initiating hits. Perfect. Awesome. So we've talked about all the fun stuff, all the serious stuff. So with that, Dr. Frye, Dr. Zissel, would you like to tell us tell our audiences what you really want them to take off of here, and we'll go from there. Dr. Zissel, Dr. Frye?
Yeah.
Yep.
Maybe my wish would be that the physician should be alerted. Occupational disease, berylliosis might be an occupational disease, but must not. That is what we think is a message of our study. And what I see is that the awareness of berylliosis is increasing, at least in Germany. That is what I really believe, because the request of the test is increasing. So,
well, I think maybe for the individual patient, I think it's the results here are not of utmost influence on his treatment or on his diagnosis. So I think we should stick on sarcoidosis, known or suspected beryllium exposure performing a beryllium LPT. However, I think that for physicians and especially for researchers, as Dr. Dweik said, it's interesting to look whether there are clusters of sarcoidosis patients, whether this clusters might lead to identification of immunogens that cause this disease, because we still, from the sarcoidosis point of view, we still know too less about it. On the other hand, I think also beryllium disease, because we have this patients at risk, we have patients that have an immune response, and we have patients that have a disease, is an interesting, let's say, model to better understand maybe steps in the development even for sarcoidosis. So to maybe to look for genetic alterations that are found in the one or the other step. And furthermore, I think that investigating the impact of dusts on the health of patients, of the health of individuals, is also an important issue that should be much more focused by health authorities.
Yeah, those are great points, Dr. Frye. Thank you for mentioning about the importance of health authorities, being cognizant about dust and exposure to dust by populations. All right. Well, thank you so much. Thank you so much to the authors for joining us, and Dr. Dweik for being our content liaison. This is a really great discussion and very interesting one, and it's definitely it's convinced me to do a better job of taking my environmental and occupational histories. So I appreciate the reminder about that. And thanks again to the authors. Appreciate everyone being here. Thank you.
Thank you for this chance.
And there's a CME available for this session. So
yes.
Oh no, that's okay.
Thank you, Viren. Yes, this is a good opportunity to earn some CME.
That's right. So just 3 simple questions, good learning there. And we just shared the link in the chat. So just click on that and you're all set.
Yeah, all you have to do is click on that link, answer 3 questions, and you'll earn yourself some CME for attending this session.
All right, Divya, Dr. Dweik, Dr. Frye, Dr. Björn, thank you so much, everything, Dr. Zissel, and continue the good work.
Thank you. Have a great day.
Thank you all.